Thank you very much for inviting me. I do have one disclosure, and that is that I'm not a thoracic nurse specialist. So do forgive me, I feel a bit of an interloper. I'm going to talk to you about acute oncology, which is a generic service that covers all acute and emergency presentations from all cancer types. So I'd like to present you an overview of acute oncology services, provide you with an understanding of the acute oncology patient groups, and some information about tools that may help in the management of acute oncology patients. Is there a problem? Well, we did identify that there indeed is a problem with the way that we look after our patients who are admitted as an emergency with an unplanned admission, resulting from either their disease or the treatment they're receiving. We had a number of reports in the UK. One in particular was the NCPOD study in 2008 that looked at deaths within 30 days of receiving chemotherapy, that identified problems with recognising toxicities, toxicity management, and presentation with toxicity on the patient's part as well. We had a review of national patient safety reports, and they concluded that 46% of severe or death incidents that were reported to them were related to cancer patients accessing emergency services. We've also had a cancer patient in crisis review that identified problems along the whole care pathway for our cancer patients. Problems were related to treatment, so poor recognition and assessment of treatment-related problems, e.g. sepsis with neutropenia and diarrhea, delay in admission, inappropriate investigation, delayed and/or inappropriate management of toxicity. Disease-related problems included poor recognition of management of disease-related issues such as metastatic spinal cord compression, failure to obtain oncology review or opinion early enough, resulting in prolonged hospital stays, and failure to escalate care. We have a number of examples that we looked at, and I use in teaching around the UK, encouraging people to look at acute oncology. And lots of the problems relate to communication and the lack of specialist knowledge at the point of entry for the patient, as you can see with this example. We also, in particular, I have a great interest with our advice line services and whether or not we are delivering a good service. And as you can see here, this was a helpline, and the telephone was just situated in a general ward on the desk, and other people answered these calls and gave inappropriate and harmful advice. So what's the demand for this? Well, we know that unplanned cancer admissions may happen several times for a patient who is going through prolonged cancer treatment and for a patient with progressing and symptomatic disease. We know these episodes relate to complications of treatment, symptoms from underlying malignancy, or an unrelated problem. We know the number of emergency admissions among people with cancer has been steadily increasing. I found some information from 2010 that said there were 300,000 unplanned admissions each year. 140,000 of these follow presentation to emergency departments and have an average length of stay of 9.6 days. When we relate this to lung cancer, we can see that 46,403 new cases of lung cancer in 2014. They make up 13% of all new cancer diagnosis in the UK. And then we look deeper and we see that 35% of lung cancer in the UK is diagnosed on an emergency admission. So this is indeed a really important tumour site that acute oncology needs to address. Very few studies about the demand and how many people do present with unplanned emergencies. But this is one that I came across, and it said that the most common malignancy presenting to the emergency department in 2016 was lung cancer patients, that stood for 17.3% of patients that presented. So what is acute oncology? Well, the acute oncology patient group are considered to be an acute emergency new cancer diagnosis, acute complications of cancer treatment, and acute complications of a known cancer. Acute oncology services should support acute medical, emergency, and primary care services by providing specialist review, advice and guidance for patients with acute problems related to their disease or treatment related. A systemic approach to dealing with cancer-related emergencies. So the key features of an acute oncology service. We want to ensure acute oncology review within 24 hours of admission, 7 days a week. This didn't always happen. Sometimes you had to wait for oncology specialist review for a number of days in some of our outlying hospitals. We want to improve safety and quality of emergency care with the development of acute oncology pathways. With the development of acute oncology pathways, protocols and training. We want to support specialist pathways in neutropenic sepsis, spinal cord compression and malignancy of unknown origin. We want to reduce hospital length of stay. We want to support cancer helplines for health professionals and patients. And we want to develop options for rapid access and ambulatory care. We want to try and ensure that the patient who is admitted at midnight into an emergency department where there is no oncology on site will receive as good care as a patient who's admitted to a cancer centre at 1:30 in the afternoon. Who are members of the acute oncology team? Well, we're all members of the acute oncology team. The patient's acute oncology pathway begins with the first healthcare worker that they present to with that current problem. We're more specific when we talk about the acute setting. And in England, we have measures that state we must have an acute oncology service in every hospital that accepts emergency or unplanned admissions. This principle has also now been adopted in Scotland, Wales and Northern Ireland, and I believe in other areas of the world as well. The core team members in the acute setting are acute oncology nurses, and they work alongside consultant oncologists and haematologists who are either work as acute oncologists or form part of a rota. The patient pathways. So this is just a very high-level diagram of how acute oncology can impact on a pathway. So when we're talking about a first diagnosis of cancer being made in the emergency setting, we want to get acute oncology involved very early in the patient pathway. We don't want them to have that prolonged period of diagnosis and investigation, which sometimes doesn't result in treatment and can also result in them bouncing around different multidisciplinary teams. We want the acute oncology nurse team to get in there straight away, early on in the pathway, and guide that patient management. We've made significant steps in getting patients with good performance status out back into their home and with a care plan and managing their investigation and diagnostics remotely and getting them into the specialist MDT appropriately. We also have very good record of managing poor performance status patients and managing their expectations and discussing what actually is the right way to treat and manage these patients, involving palliative care early, getting senior acute oncology review very early, managing investigations and supporting appropriate discharge. In the West Midlands, we have, which is my area, we have a 34% of lung cancers are diagnosed in this emergency setting. When we talk about non-surgical therapies, we've got two entries into the pathway. So pathway one is that the patient contacts the 24-hour advice line. Almost all the advice lines in the UK now use the UCON's 24-hour triage tool, which has been in use since 2010 and was developed in 2007 and piloted in 2007. They use a triage RAG rating score, looking at symptoms, not necessarily the disease or the treatment the patient's on, but what symptom is the patient presenting with. And they will either be allocated green, which is advice only, 1 amber, which is follow-up within 24 hours, but monitoring, or red, which is escalation and asked to come in for further assessment. Acute oncology gets involved mainly at that further assessment process, so once the patient arrives in the acute setting for further assessment. Acute oncology will also go down to emergency departments and see patients who present there with problems related to their treatment or disease. Again, escalating that pathway, making sure that patients are admitted, investigated appropriately and sent home appropriately. They also have a role in liaising with the clinical care team. We did find in one of the studies that I took part in, the MCPOD study, that actually patients could have emergency admissions to one site and then have their treatment delivered in another site, and they wouldn't communicate at all, and they didn't know the patient had been admitted as an emergency. So we have a real responsibility here to improve the communication and make sure that everybody knows what's happened to these patients. With the patients with a known cancer, again, sometimes these patients used to flounder for quite a long time. They were admitted under the acute medical take, and they would wait for a long time for oncology review, and inappropriate management would take place. So now we want to get in early, but we're also offering primary care referral. So if our primary care teams want to get straight back into oncology, they can do that through acute oncology as well in some cases. What can we do in the acute oncology pathway as far as tools and support? We're just about to release an education and competency framework for acute oncology. It's a 4-tier framework that addresses all healthcare professionals. It's multidisciplinary. It sort of describes what level of acute oncology knowledge you should have from being an ambulance technician to a consultant, and works its way through these 3 descriptors. So we're very clear about who should know what and when, and how they should be assessed as competent. So you can see the 4 levels there. I won't go into them in detail. We've just released now the primary care risk assessment tool. So this is a tool that can be used by healthcare workers in the primary care and community and district. It's multidisciplinary again. We worked with Macmillan GPs to develop it. It's based on the UConn's triage tool, and again, based on symptoms, and will alert the user when they should be concerned and direct them to the right point of advice. So where can they go to get advice about what to do with this patient who's presenting with this symptom? We're strongly linking that to the 24-hour advice lines so that they can have the triage and they start that communication with the acute care setting straight away. This has been very well received. It's been used by pharmacists, practice nurses, and district nurses and GPs. So the advice lines, and this is my particular favourite because I helped develop the 24-hour triage tool for UConn's. And this is a symptom-based, RAG-rated system by which you assess the symptom the patient calls with. We use the CTCAE, but we also have a cumulative scoring system. So the sort of middle-level toxicities, if you get a number of those, it adds up. So if you get 2 or more ambers, then that escalates to a red, and that would encourage you to bring the patient in for assessment. This is used very widely in the UK now and has prompted some really significant developments in advice lines. We've now got a number of regional advice lines who actually specialise in providing advice. They don't sort of work within the oncology unit. They work separately, and they are the triage advice lines. And I had some data hot off the press on my way here yesterday from one of those advice lines. They worked out that 35 to 40% of patients who contact the advice line go on to come in for assessment, for face-to-face assessment. We can see that lung cancer patients are the 3rd highest users of the advice line, and that's after colorectal and breast. In the advice line service for Lancashire, the central advice line service for Lancashire provides out-of-hours care, and they had 3,277 out-of-hours calls in 10 months. And in 9 months for the Shropshire Care Line, they had 1,944. So this is a big service that we're providing here. And you can look at it that actually we've left 60% of patients at home supported that could have probably ended up presenting to our emergency department without this advice line service. All our patients are given 24-hour advice line numbers to call. And we are actually looking at, UConn's are looking at now whether we can develop a national alert card. At the moment, we tend to give it out organisationally. This is the Scottish one, but we tend to give it out organisationally. So I think we're going to look at developing a national one. And we're also developing acute oncology guidelines, and these are particularly aimed at our acute medical colleagues and emergency department colleagues, because it's great that we send our patients there, but we don't actually share our knowledge and skills very well with them. So we're working really hard to become part of their team and work with them to provide them with guidance when we're not there. So these guidelines, there are 40 in total. They cover 3 areas. So one is the symptom guideline. Then we have the immunotherapy guidance, and that's endorsed by the ESMO guidance and the National Endocrine Group in the UK. And then we have condition guidance for things like hypercalcemia, SVCO. They're in draft 5 now and should be out by the end of the year. So what's on the horizon? Well, we've got the new treatments, the immunotherapies that are coming along regularly now. We did actually update the UConn's triage tool not very long ago so that it does address immunotherapy issues now. And we've added in a few more sort of categories to the list. We're looking at a low-risk sepsis protocol that might be adopted nationally. We're very keen to look at where we can avoid admission to hospital wherever we can. So we're also looking at acute oncology services in community and point-of-care testing. Some very interesting models where acute oncology nurses will go out to assess possible MSCC patients to decide whether or not they need to come in. And we're also developing a patient systemic anti-cancer therapy diary. We had a quite successful diary some time ago that actually contained a patient risk assessment that was colour-coded and RAG-rated, and the patients really appreciated it. It was very clear about when they should be concerned about a toxicity and when they should come in. So we're trying now to develop a national diary that's going to be included in. So my take-home messages are: unplanned cancer admissions may happen several times for a patient who is going through prolonged cancer treatment and for a patient with progressing and symptomatic disease. We should prepare and educate the patient that this may happen and help them plan, and that's what we're hoping to do with the diary. Ensure that all professionals involved in the care pathway can recognise acute oncology presentations and take appropriate action. Ensure that specialist support and advice is available 24/7. Develop functional acute oncology pathways for ambulatory and inpatient care, and support our urgent care colleagues by sharing our knowledge and skills. It's not much, is it? We can do that. Thank you.